Okay. Good morning, everyone. Hope you all had a good sleep last night. And I'm going to talk about narcolepsy today.
So the patient list.
Before I start, here is a question for you all. When a patient comes with excessive daytime sleepiness, what differential diagnosis comes to your mind?
Sleep apnea.
Yeah, sleep apnea, that's very common.
Thyroid disease can be too.
Sure.
You need to take a
Right.
to make sure why the patient is tired.
Exactly. So there are numerous possibilities, and I tend to think of the easier ones first. For example, insufficient sleep due to shift work, or medications and substance abuse, which can be simply managed with sleep hygiene or avoidance of those agents. And we know there are many sleep disorders. The most common ones are breathing disorders, including obstructive or central sleep apnea, and sleep-related hypoventilation or hypoxemia disorder. The second common ones are central disorders of hypersomnolence, which narcolepsy belongs to. Also, circadian rhythm sleep-wake disorders and sleep-related movement disorders such as restless leg syndrome, periodic limb movement disorder. Other neurologic disorders may also cause excessive daytime sleepiness, for example, Parkinson's disease, dementia with Lewy bodies, Alzheimer's, multiple sclerosis, myotonic dystrophy, and brain injury. Don't forget about medical disorders, including hypothyroidism, adrenal insufficiency, hepatic encephalopathy, and end-stage renal disease. Last but not least, psychiatric disorders such as depression, bipolar disorder, and anxiety. So, narcolepsy is one of the most common causes of sleepiness next to sleep apnea. It is a clinical syndrome of daytime sleepiness with cataplexy, hypnagogic hallucinations, and sleep paralysis. All patients have sleepiness, but only 1/3 of them will present with this classic tetrad. It is equally common in men and women, independent of races, and typically begins in the teens and early 20s. Based on the presence of cataplexy, narcolepsy can be classified into type 1 with an estimated prevalence of 25 to 50 per 100,000 people, and type 2 with a bit lower prevalence. Cataplexy is highly diagnostic of narcolepsy. It is characterized by sudden, emotionally triggered episodes of muscle weakness with preserved consciousness. These episodes typically begin with weakness of the muscles of the face and neck, and may spread into muscles of the limbs and trunk. Interestingly, the triggers include telling a joke, laughter, excitement, anger, or grief. The weakness often resolves within 2 minutes. As I said, this is very specific for narcolepsy, but it is not present in all the patients. It develops within 3 to 5 years of the onset of sleepiness in 60% of people with narcolepsy. As for the etiology, narcolepsy type 1 has been well studied. It results from the loss of orexin A and orexin B, also known as hypocretin 1 and hypocretin 2, in the lateral hypothalamus. These neurotransmitters promote wakefulness, prevent inappropriate transitions into REM or non-REM sleep, and inhibit REM sleep. Remember that cataplexy, hypnagogic hallucinations, and sleep paralysis are all related to REM sleep. The DQB10602 haplotype is present in 95% of patients with cataplexy, but this is not specific. It can be seen in healthy people too. Researchers suggest that an autoimmune process may play a role. For example, there was an increased incidence of narcolepsy in children who received H1N1 vaccines in Finland. On the other hand, the cause of narcolepsy type 2 is unclear, and most of these patients have normal CSF orexin A levels. Some people suggest that it may develop into type 1, or it is due to impaired functions of orexin receptors, or by a totally different mechanism. Clinical assessment is essential for diagnostic evaluation of narcolepsy. The following questions may be helpful in detecting possible narcolepsy. First, are you sleepy most of the day? Do you feel rested upon waking in the morning? Are your naps refreshing? Because most of the narcolepsy patients feel rested or refreshed after waking up, in contrast to patients with sleep apnea. Next, do you have vivid dreams during daytime naps? This is for possible REM sleep. Do you ever have muscle weakness when you tell a joke or laugh? Again, this is cataplexy. Do you ever see, hear, or feel things that you know aren't there as you are falling asleep? This is the definition of hypnagogic hallucinations. And are you ever unable to move when you first awake or just before falling asleep? This is sleep paralysis. And lastly, over the past 2 weeks, how often have you fallen asleep when you did not intend to? This implicates functional impact of daytime sleepiness. If the answer to any of these questions is yes, narcolepsy should be considered, and both a polysomnogram and a multiple sleep latency test should be performed. Sleep studies are most commonly used objective evaluation for narcolepsy. On polysomnography, narcolepsy patients typically demonstrate spontaneous awakenings, mildly reduced sleep efficiency, and increased light non-REM sleep. Patients with type 1 and occasionally with type 2 may show REM sleep within 15 minutes of the onset of sleep. In contrast, healthy people enter REM sleep 80 to 100 minutes after the onset of sleep. As for multiple sleep latency test, MSLT, on average, healthy subjects fall asleep in about 10 to 15 minutes, whereas people with narcolepsy often fall asleep in less than 8 minutes. The naps of patients with narcolepsy often include REM sleep, and the presence of 2 or more naps containing REM sleep, known as sleep onset REM periods, are an essential feature of narcolepsy. CSF orexin A level measurement is primarily a research tool, but can be used in certain clinical situations when the MSLT is difficult to interpret. For example, poor nighttime sleep, inability to discontinue antidepressants or other sleep modulating medications prior to testing, when the patient is a young child, or the patient has atypical cataplexy. Here is the diagnostic criterion for narcolepsy type 1. both of the following must be met. 1. Daily periods of irrepressible need to sleep or daytime lapses into sleep occurring for at least 3 months. 2. At least one of the following. A. Cataplexy plus a mean sleep latency of at most 8 minutes and 2 or more sleep onset REM periods on an MSLT. B. CSF orexin concentration is low. For narcolepsy type 2, all of the following must be met. The first compartment is basically the same as the one as type 1, except that cataplexy is absent and CSF orexin concentration is either not measured or higher than the cutoff values. In addition, the hypersomnolence and or MSLT findings are not better explained by other causes such as insufficient sleep, obstructive sleep apnea, delayed sleep phase disorder, or the effect of medication or substances or their withdrawal. As I mentioned before, cataplexy is very specific for narcolepsy, but we should differentiate it from pseudo-cataplexy, which can be seen in conversion disorder or functional neurologic symptom disorder. There was a study comparing those two motor features, and they found that cataplexy happens more frequently than pseudo-cataplexy, and there are certain triggers in most of cataplexy. Interestingly, the triggers are positive triggers are more prevalent in cataplexy, such as laughter or telling a joke. And in conversion disorder, there can be other prodromic symptoms. In addition, partial weakness is more prevalent in cataplexy compared to pseudo-cataplexy. Narcolepsy type 2 is sometimes difficult to diagnose because of the lack of diagnostic cataplexy. And when we are to diagnose it compared to idiopathic hypersomnia, there are several aspects to be careful about. Diagnostic criteria for both are largely the same, except that sleep onset REM periods are 2 or more on an MSLT in narcolepsy type 2, whereas they are fewer than 2 in idiopathic hypersomnia. Also, patients with narcolepsy commonly complains about sleep maintenance insomnia, but people with idiopathic hypersomnia can sleep for 12 to 14 hours each time, typically. So after the diagnosis, we can manage the patients with both non-pharmacologic therapy and pharmacologic therapy. We consult patients about sleep hygiene and psychosocial support. We can also recommend napping during work or school if it can be arranged. 1 or 2 well-timed 20-minute naps will often improve sleepiness, although some patients only benefit from long naps. Also avoid certain medications, including benzodiazepines, opiates, antipsychotics, and alcohol. Theophylline or excessive caffeine can cause insomnia and often worsen daytime sleepiness. and also prazosin and other alpha-1 antagonists can worsen cataplexy. Health maintenance is also important because depression and anxiety can be common in narcolepsy patients, so screen them at least every 1 to 2 years. Also manage obesity, hypertension, and diabetes. They can be seen either due to lack of sleep or the use of medication for narcolepsy. As for pharmacologic therapy, for daytime sleepiness, first-line medications are modafinil or armodafinil. Last year, FDA approved new medications, including solriamfetol, which is an oral selective dopamine and norepinephrine reuptake inhibitor, and pitolisant, an oral histamine H3 receptor inverse agonist. They can be potential first-line medications with increased clinical evidence. Second-line medications include other stimulants such as methylphenidate or amphetamines. They are effective, but due to their sympathomimetic side effects, they are not used as first-line therapy. For cataplexy, there are REM sleep suppressing drugs, mostly antidepressants. Those can selectively inhibit the reuptake of norepinephrine or serotonin, including venlafaxine, atomoxetine, and fluoxetine are usually used. Low doses of tricyclic antidepressants can be also used on an as-needed basis just before social events. Be careful that abrupt withdrawal from any of these antidepressants can trigger status cataplecticus, which is severe, nearly continuous rebound cataplexy that can last several hours. Another medication is sodium oxybate. It is a metabolite of GABA, but its precise mechanism of action is unknown, and its access is restricted in the United States due to potential for abuse. That's all for my presentation. Thank you for your attention.
Thank you.
Thank you, Dr. Tao. It was great.
Any questions?
I have a question. I don't know if they have any information about why these triggers like laughter or crying cause the cataplexy.
That is a good question. I haven't found an explanation for this, but it is a great question to study about.
Dr. Stan, are we still recording? Or
I had a quick
you want
question.
to continue?
There's a thing called the long sleeper, which probably is the same thing as idiopathic hypersomnia. But there have been a few times I've had to write a letter for a student in college who could not get up for his courses in the morning, and he was being disciplined, but we took him in his sleep lab, and he actually required 10 to 12 hours of sleep a night, and we had to adjust his college courses so he could get his sleep. So sometimes the doctor has to write a letter to explain this.
Yes, true.
Yeah. Okay, I'm going to stop.